Hi, good morning, everybody. Today, I hope all the participants are there. How many participants are there today? Till now? 30. Okay. So, today we'll have, part 2 session on health. So, we'll continue with our discussion on health, and today, particularly, what we'll try to cover is HIV/AIDS and tuberculosis. Now, before I start today's session, I will let us see that what are the major questions we had last time, and I will try to answer those questions. So I see that two broad questions have come up. One really broad question. Quite a few of the participants have asked about the assignment, and broadly, some people have asked that how to select the assignment. Now there are 2-3 parameters I would say that how do you select your assignment. One, definitely you look at your personal interest, that what exactly really drives you to do something. You might be a little bit of analytical, you want to do a little bit of research. If you are program oriented, do a little bit of program planning. If you want to you are really interested about NGOs, if you want to assess any NGOs, you do an assessment of any NGOs. So there will be many, if you are trying to, and another point is that, you'll have to see that the organization you are working with, if there is a specific requirement, like we have already got somebody who has selected to do an assignment on CSR policy. So if some organizations, you are still in the process of developing CSR policy, then definitely that could be one of those assignments you might like to pick up. Last time, as many people have expressed their interest that, what the last batch had taken up. As far as I remember, the last batch had taken up corporate policy, quite a bit of number of people, because it was in the last financial year, and by that time we were supposed to give the CSR policies. All the companies were supposed to give the CSR policies, so that quite a few people, they were interested about CSR policy. Few people wanted to do situational analysis. One organization, I remember that they wanted to do an education program in and around their community. So they wanted to do situation analysis in the on education in that particular community. 4-5 people who joined together, and they developed one NGO assessment template. It's a due diligence template. So that was another very interesting assignment they have done. So what last time in the last batch, what we have done is that even few people, they came together, and they did some assignments in collaboration. So that could be another good idea, that if you really want to do something which is generic in nature, like if it is an NGO assessment tool or due diligence tool, or it is a reporting format for the CSR or anything like that in generic, what you think that could be useful for many industries and many organizations, that could also be done in collaboration. So there was actually a diverse set of assignments last time. I remember another assignment, I think from Qatar, somebody did. They wanted to develop a program on road safety. So again, that particular interest was their organization's interest. They wanted to do some CSR program on that particular theme, and they wanted to develop that particular program planning through this assignment. So I would say that one is that your organizational requirement, that could be, definitely we'll have to take consideration of the time constraint for this, and definitely we see that we don't have an opportunity to have face-to-face discussion. We'll have to consult on telephone or on internet, email. But at the same time, if there is any requirement, your organization's requirement, what you are working on or you are supposed to work on, then probably we can, try to do that together as much as possible. If there is any of your personal interest that you see that, this could be a good asset for your career, like, you developed a tool, you developed a template, for as an individual, that could be a good, asset for your or credential for you, then definitely you might look into that. And also you will have to see that, your professional background, experience and expertise, that definitely one of the core things you will have to consider before selecting an assignment. Because, today, if say, I want to take up something about technological innovation. Now, for me, that is a new area to work on, right? So for technological innovation, probably I need a lot of study, need a lot of groundwork, then only I can start doing that assignment. So given the time constraint and the limitation in the consultation and all these things, so probably that might not be a right thing to do for me, and that might, I don't have the scope to do that within this particular training program. So broadly, I said that, personal interest, your personal expertise and experience, your organizational requirement, those are the things you'll have to think, and then you will have to consider the kind of scope and opportunity you have within this particular training. Another broad question, and till now I have got quite a few assignments. People have actually expressed their interest and they said that what are the assignments they will be doing. So I would say that if you are selecting the assignment, try to select it as soon as possible, as I have told you earlier also, so that you have enough time to interact with me and we have enough time to actually through that consultation process to do that assignment. Whether you will do 2 assignments or 1 assignment, entirely up to you, but I would say that, better to finish 1 assignment in a proper manner, then pick up the 2nd assignment, but you can select the themes right now. But while you are doing that, don't make an attempt to do 2 assignment, together. You first do it one by one, so that, you can actually first finish 1 assignment in a proper manner and then get into the 2nd assignment. Because whatever the assignments we are doing, let's try to make it in a proper manner, so that, we at least we can tell and we can show that we have done a good work. And it should be useful for you or your organization, whatever it is. The another question was that what is the success rate of ICDS? Now, there are several studies. I would not say that it was a rate of it was a rating study, but there is number of reflections on performance of ICDS. In that, we see that first of all, ICDS as the largest child development program in the world has quite a bit of scale, quite a bit of reach out, but at the same time we see that the problem again is in the outcome. Now, if you look at the outcome, as last time we had discussed on the nutritional status, educational status, the status of the preschool children from birth to 6 years. So we see that it is not a very encouraging scenario what we have in India. So if you look at the outcome of whatever the initiatives, one of those initiatives, the major initiative is definitely ICDS. We see that not much of a success we actually have achieved till now, but at the same time, I would say that the challenge is too big, so that it is not only it is not that we'll have to criticize ICDS or government programs. Definitely, they have their limitations and they have their strengths, but at the same time, I would say that the outcome we would like to have, definitely we have not achieved that outcome. And that is what I said that, and always whenever I actually give advisory, offer my advisory services to the corporate, I say that, if we can have more complementary program to the existing program, and let us not have standalone programs or parallel programs, so that we can actually, with minimum input, we can achieve maximum output out of that. Because as I said, that programs like ICDS and other things, if we bring in very strategic small input in that program, we might actually see very, very significant improvement in the program delivery and the outcome of that program. So this is what it is. With that, today we have picked up two specific themes. One is HIV/AIDS, and second thing is tuberculosis. And both of these require a lot of discussion, but as you know that we have our time constraint, and so that I will try to cover these two big topics today itself. What I will do is that I will not today do a recap session. At the end of the session, if we have time, then we'll do the recap of the last session. So straight away we'll start with HIV and AIDS. If you look at this slide, what I have done, it is a very extensive information I have tried to give in this PowerPoint presentation. So it is not that all the slides, all the information, all the points what is there in the PowerPoint we will be discussing today, because really we don't have that opportunity to discuss everything today, and it is not possible to actually cover everything in one day. But I have kept all these points and all the information in the slide, so that as a referral material, you can use this slideshow in future if it is required. So again, this PowerPoint would be uploaded in mycii.in, and it would be uploaded also in csopartners.org.in with the voice recording, so that if at any point of time, if you require to download this PowerPoint, you feel free to download that and use the information what is there in that. Now, as I said that today probably we will not have time to do recap of the last session, so I'll skip all these slides and go straight to HIV/AIDS. Now, many a times we see that in common use, we use the terms HIV and AIDS to mean something, but we need to first of all understand that HIV/AIDS, these are two different terms and they mean something very different. Now, what is AIDS? As we all know, that acquired immune deficiency syndrome, a group of potentially life-threatening condition caused a result of progressive decrease in body immunity consequent to infection by human immune deficiency virus. Now, AIDS is the syndrome and HIV is the virus. So one person, if that person gets the virus and once it is infected, then that person might create that range of syndrome of that virus, then only we'll call that person is having AIDS. AIDS is a syndrome, is a set of syndrome, but HIV, it does not mean that a person who is having HIV infection, that person has all of them have actually developed that syndrome. There's a window period, it actually, after that window period only, that AIDS syndrome might be developed. Now, that is why when we'll be using the terms HIV and AIDS, let us actually start using this term in a proper manner, so that HIV will mean about the virus. When we'll say that a person is having HIV, means a person is infected by the HIV virus, right, or HIV. Broadly, what we say that people living with HIV, right? So, it might be before the, it's a more generic term, it's more inclusive term to say that people living with HIV, because then whether that person has actually crossed that window period, has started showing the syndrome or not, but still the people, we can actually generically use that people living with HIV. Now, specifically who are having those syndromes, for them we can say that people living with AIDS, right? So that how it is transmitted, we know, all of us know probably, but still, just to refresh your memory, it is through unprotected sexual intercourse with an infected partner. Vertical transmission, this is from mother to child. It might be in the utero. It might be during delivery. It might actually be transmitted through breast milk also. And also the another thing is injecting drug use. So if you use an used syringe, and which is used by an infected person, the same syringe is used for the other person, we might get the transmission through blood. Now if you see all the transmission, 85% of the transmissions of HIV is through sexual intercourses. In 2.39% is IDUs, blood and blood products 2%, perinatal 3.6%, and others 6.0%. So that we see that highest number of or highest percentage of transmission happens through sexual way. The second is others, definitely there would be number of causes. Perinatal, that is from mother to child. And then blood and blood products 2%, IDU is 2.39%. So that most of the sexual, transmission is happens through sexual channels. Now, how do we diagnose HIV/AIDS? As you know that there are few tests. One test is ELISA, Western blot, rapid HIV test. Through that, what we try to see is that largely by the detection of antibodies against HIV in the blood of infected patients. So through these tests, we actually try to see that whether that person is HIV infected or not. Now, many of these tests sometimes give some false results. Why? One example is that if somebody is still in that window period, just infected, got that virus in the blood, in the body, and has not really developed the AIDS, it might so happen that for 30 to 60 days, the test will show negative result. That means that person is not having HIV in his or her body. But if you repeat it again after 30 to 60 days, again the result might show that the HIV is existing in the body. So sometimes what happens is that repetition of the test after 30 to 60 days is required to confirm. Equally, sometimes actually what happens, a negative, it's so also happen in lab errors that some negative, some person does not have the HIV. It might happen so that, the test is showing HIV. But if you do it, because of that, the confusion in the antibody, you see that in ELISA test and all these tests, there is a chance in, changing the colors and all these things, which is actually, wrongly indicate the presence of the virus. So that it is always suggestible that in 30 to 60 days, somebody should do a repeat test to confirm the status. Now, as I said, that around 85% of the transmissions are through are sexual transmissions. 85% are sexual transmissions. Now, let us see that, what are the efficiency of transmission? That means how much risk is there through sexual transmission? How much risk is there for blood transmission through blood? How much risk is there for perinatal? So in that, if you see that the efficiency of transmission for blood transfusion is 90 to 95%. So that if anybody is getting a blood or infected blood, 90 to 95% chance is that that person will get also infected. Now, if you look at the contribution to total number of cases through blood transfusion, what is the percentage of people who are getting HIV? Is only 5. So only 5% of the infected people, they get that infection through blood. Though blood transmission is one of the most efficient way of contamination. In India, it is only 3%. Sexual intercourse, a perinatal, let us see the second point, perinatal. The efficiency of transmission is 20 to 40. That means 20 to 40% chance is there that the baby will get HIV infection from the mother, either through womb or through breast milk. Now, only globally 10% of the infected children are actually infected perinatally. In India, the number is only 3. So that very minimum number of infected children who are actually getting that infection through the mother's womb. Now, there are many other factors like, whether the mother is on ART, antiretroviral therapy, whether, the mother is taking all the kind of precautions and not, whether they have that access to medical system and not. So there are a lot of other factors, but generally if you see that the highest risk of transmission is through blood transmission, the second highest risk is through mother to baby, parent to child transmission. Then sexual intercourse, it has only chance from 0.1 to 1%. So that if somebody is having a sexual partner who is infected, they have 0.1 to 1% of transmission, but 75% of the global cases and 84% of Indian cases, infected persons, are getting the infection through sexual intercourse. Now, this is something we need to understand. Even the media is not so efficient, but still more and more people, highest number of people are getting this infection through that particular media, sexual intercourse. Then what it is, right? So, the major factor in this is the behavior, the behavioral part. So, the sexual behavior is actually playing probably the most important role, for transmission of HIV and AIDS globally and in India. I would say that transmission of HIV, sorry, it is not AIDS, HIV globally and in India. Now, injecting drug uses, its efficiency is 0.5 to 1%, and it is contributing to 10% of the total infected in globally and 3% in India. Needle stick exposure is very minimum in India. Actually, we don't have data about that. There might be some cases, but it is not so significant. So that, what is our takeaway from this particular finding? The takeaway is that the most efficient medium is blood transfusion, but not too many people. In India, only 3% of the infected people are getting that infection through blood transfusion. The highest incidences of infection is happening through sexual intercourse, though sexual intercourse as a media is not that efficient, only 0.1 to 1% efficiency, but 75% globally and 84% cases in India are getting through sexual intercourse. So that if we want to see that, where actually what should be the major strategy in prevention of HIV transmission, then probably, we'll have to do something about the sexual behavior of people, or we'll have to promote safe sex behavior. Definitely, 3% is also a big number. In India, we have 2.1 million, people who are infected, and that is the third highest number in the world. Yeah, and 2.1 million people are having the infection, means it's actually quite a big number. Now, if you compare this 2.1 million people with malnutrition, with the number of people who are dying in road accident, with the people who are dying in tuberculosis, malaria and all these things, comparatively it will look smaller. But when we try to assess a particular risk or particular problem, then we'll have to assess in terms of, definitely one is scale, that how many people are infected, for how many people this problem is. Second thing is the severity and also the intensity of the problem. So in this case, probably the intensity and severity is so high, even it is comparatively 2.1 million is a big number, but if you compare with other things, then probably it will look little smaller. But even then, because of the severity and the intensity of this problem, we'll have to take it very, very seriously. Now, what happens after the infection? What happens is that the immunity system get reduced of a person, get destroyed of a person, and they get started getting different kind of infections. So HIV, that is why it is called syndrome. You know, AIDS, acquired immune deficiency syndrome. So by itself, it is not a disease, it is a syndrome. What happens is that by this, the immunity system of a person gets destroyed, and because of that, that person starts getting infection, different kind of infection, and these infections are called opportunistic infection. One of the major opportunistic infection is tuberculosis. Then we have candidiasis, we have chronic diarrhea, Hopper, toxoplasmosis, pneumonia, retinitis, meningitis. So all these, these are all common infections in Indian tropical and other countries, in even African countries. So if you see that, a person who has already developed AIDS, the syndromes, they start getting different kind of infection, and this infection management becomes a very, very important treatment for these people. Now, if we look at the prevalence, we see that if we compare from, in both the charts, if you compare, the left is for the adult HIV prevalence. If you look at 2000 data and 2011 data, definitely it is reducing. In case of children below 15 years, it is almost stable. It is not reducing. It is not a declining trend so much. So that is a concern. Now, if you look at globally, there are 35 million people living with HIV globally. Out of that, as I said, that 2.1 million people are living in India. So it's quite a bit of a number. 70% of the people living with HIV are located in sub-Saharan Africa. The highest number of people are in South Africa. There are 3.2 million children and 2.1 million adolescents living in HIV. There are 4.2 million people 50 years and older living with HIV. So that if we see that, in all age group, people have infection and they are living with HIV. And if you look at these texts, the way we have used that, there are 35 million people living with HIV globally. So that whether they have developed AIDS or whether they have just got that infection, we mean all these people who are having HIV in their body. So 35 million, out of that, as I said, that 2.1 million people are in India itself. 70% in sub-Saharan Africa. Now, generally what happens, when we talk about HIV/AIDS in general forum, we talk about the life threat. We talk about how many people are getting infected. We talk about their health situation, the opportunistic infection. But if you see HIV/AIDS now as it has emerged, it is not only a health problem. It has developed a lot of other problems, social problems, psychological problems, financial problems, human rights problems. So that if we look at HIV or HIV/AIDS, then we'll have to actually understand that this is a more holistic problem than the health problem itself. So it has created it has snowballed rather, has a lot of other problems around it because of stigma mainly and discrimination. So stigma and discrimination, health aspects can be managed. You can actually start antiretroviral therapy. You can start, taking care of these people medically. But unless and until we really address those issues of stigma and discrimination, it is very, very difficult to handle the situation. So that when we try to understand the problem of HIV/AIDS, I would say that let us try to understand the problem in entirety. It is not only the health problem, it is not only a medical problem, it's a social problem, it's a psychological problem, it's a financial problem. So that if you look at that problem in that manner, then you will try to see that how do you then address that problem. Now, why and how people living with HIV/AIDS are being left behind. Now, say today if I have in India we had different kind of, and that is something we need to understand, that we had whatever the communicable diseases we had, like, we had leprosy, tuberculosis, all these diseases are attached with some kind of stigma and discrimination. Though nowadays actually, it's much better than before, but still you will find that somebody who is having, TB infection, they are not happy to actually share that with anybody else, that, they are having tuberculosis. Even, if you look around your friends, and, we'll be seeing that, many of us also are probably infected with tuberculosis. If you look at the statistics, though we are not developing the symptoms, but still we probably have the infection, but still it is very, very difficult for people in India and many other countries still that to share that with anybody else. If some of us get a leprosy, right? I mean, these are now very much treatable. These are now very, very small disease. It is not that kind of life-taking disease nowadays with the kind of treatment we have and all. But still, if I have leprosy, and if you know that I have leprosy, definitely, it's a kind of stigmatized area, and you will see a lot of discrimination about that person. So, if you see that as a person, if you see their perspective, from their perspective, it is not only their health problem. A person who is having HIV, definitely you just try to understand their anxiety and agony in their lives, because they know that what kind of health problem, the pain they are going through, physically. But at the same time, they are subject to a lot of discrimination, stigma in the society. Family members, they also, leave them, and many times these people actually are left with no care, no support from the family, from the community. Sometimes they lose their jobs. So when we try to understand from that perspective, from that person's perspective, then we'll have to see that it is not only his health problem, probably much bigger problem is the stigma and discrimination. Now, since the start of the AIDS epidemic, more than 78 million people have been infected with HIV and 30 million have died. Acquired HIV no longer means a certain no longer means a certain death. Definitely, once a person is infected, we have now a lot of good treatment. So it is not that immediately the person will die, or the person will die at all for the HIV/AIDS. We can, for antiretroviral therapy, we can actually save a lot of lives, and also we can increase the lifespan. Only 2 out of 5 people living with HIV have access to antiretroviral therapy. So only 38%, 2 out of 5 people. Among people who don't have access, great inequities exist. So that, if you see that ARV, antiretroviral therapy, ART, only 2 out of 5 people, they have the access to ART. And if you see that, the financially who are not that better off, definitely they have the problem to access. If you see that, again, the gender divide is there, so that the discrimination is there even to have an access to right kind of healthcare system for these people. People living with HIV are being left behind because they are not benefiting from healthcare, employment, education, or social protection. This is often due to stigma, discrimination, prohibitive laws and policies. In many countries, they have prohibitive laws and policies or lack of services. You just think about a corporate. Within that corporate in India, we have hundreds of cases that in big corporates also who talk about corporate social responsibility, who are doing, responsible business, etc., etc. When they come to know that one person is infected, we see a lot of discrimination about that person, and last of all, probably that person end up losing his job or her job from that particular corporate. So that, disclosure of the status is also difficult for people, because they know that if they disclose and if let others know that, if they have infection, then probably they might be subject to different kind of discrimination. Now, if you see in this, if somebody is infected, a person living with HIV, that person faces these issues. So that, as I was saying, that you'll have to see from that perspective. If you first look at the green balloons, I have no one who understands, right? So it's actually, I have seen many cases that where people are left alone. The family members, their parents, even sometimes their children, their spouses, they have actually left that person. And it is not only because of the contamination, it is also a lot of social stigma is there, that this person has done this, that means having HIV or have developed already AIDS. So this person has done something very immoral, and that is why this person is suffering from this, and this person is actually bad. It might be through sexual intercourse, it might not be, but still, once they get the infection, they are subject to discrimination and stigma. Then if you see the next balloon, I have a right to dignified care. Definitely every individual, every human being, infected or not, they have the right to dignity and care. And once we know again that a person gets HIV infection, they probably don't really get that care and dignity. Now, I had the courage to seek treatment and care. If you look at the blue boxes, blue balloons, I am proud to help my peers living with HIV. Right? What are at the back side? If you look at the blue balloons from the top, I may have tuberculosis because of this opportunistic infection. As I said, that once that person is having infection and develops that stage of AIDS, then they start getting a different kind of opportunistic infections. In many countries, even in India, they get criminalized because immediately people start saying that, oh, definitely you are having, illegitimate relationships, you are going to brothels, you have sexual relationship with people who are infected. So almost we treat them like a criminal. I do not have access to treatment. It might be financially, it might be because of the reach of the treatment centers is not much. I face discrimination from health staff, even in the health of, we know many cases in India has happened that in big hospitals an HIV infected person has gone for the treatment of the opportunistic infection or many other treatments, or maybe something else. In many hospitals we see on the doctors, they refuse to treat that person in the fear of getting contaminated. My status was disclosed without my consent in many cases. So it is a consented disclosure, so that even the testing of HIV status without consent by protocol we cannot do. Few months back, I was visiting one of the corporates, and I'm an advisor to that particular company, and they were planning to develop a program, a screening program for the contract laborers and especially the truckers who come there and stay for a couple of days probably with that to supply to get their transports and all. And they almost started, finalized a plan to do a compulsory testing of all these people, all these contractual laborers and the truckers and all these kind of people. Now, first of all, there is a protocol, and legally you cannot really force somebody to go for a testing of their HIV status, infection status, or even to disclose that. So that the only way, this is a voluntary, like you and me. If I don't want to go for a testing, and no government or no employer can actually force me to do a testing and disclose my health status. So I can be arrested for exposing my partner to HIV. In India, we have many cases. It has happened. Nowadays, actually, it's much better situation. In other countries, definitely it is there. My family may reject me, as I said. I'm scared that I will lose my job. The top 4 reasons why people living with HIV are being left behind: human rights violations, stigma and discrimination, access to treatment and services, gender-based inequalities, criminalization and exclusion. Now, I'm not getting into the detail of that. If you are interested, you might actually go through all the slides. Again, these slides would be available for you. Just download it and go through that. You can get more details of that. And there is a very interesting study called GAP Studies, which is done by UNAIDS. So you might actually refer that document. We'll be sharing the document with you later. So you can see that, you can get more detail about the suffering of infected people. Now, I'm not getting into all these very, very detailed statistics. Now, let us actually look at this at least. About 68%, about 6,000 new HIV infections a day in 2013. So, every day in worldwide, we are having 6,000 new HIV infections worldwide. Out of that, 68% in Sub-Saharan Africa. As we said, that 70% of the people who are having infection, they are in Sub-Saharan Africa. About 700 are in children under 15 years of age out of 6,000. About 5,200 in adult aged 15 years and older. Of him, almost 47 are among women. About 33% are among young people. So that is the kind of trend. Now, if you look at these statistics, that we see that 70% of children, 70% of the infected people in Sub-Saharan Africa, and let us see that, and the third highest number of people are living in India who are infected. Now let us see that how many of them are getting the ART, antiretroviral therapy. Now, as you can understand that this is the only treatment. So how do we understand that there is that person is having infection? There is something called CD4. CD4 cell. That is a cluster differentiation 4. That is the name of that particular cell, and that is called, and that is found actually in the surface of immune cells. It is called the helper cell because what the role of this particular CD4 is to give signal to the other immune cells who will act against that virus, and this particular CD4, which is actually giving the signal, that gets destroyed. Okay, so that once that person is infected, that CD4 counts actually gets down. So once that count gets down, then immediately and with also the strain, we can see that whether that person is infected or not. Now it's like it's a immunoglobulin. It's a protein. It's a glycoprotein which is actually found in the surface of the immunity cells. Now, to increase that, what again we do, that the treatment is there is that ART, antiretroviral therapy. So if you see the access of ART, who are accessing that is globally, if 100 people are accessing ART, then 33% in South Africa, 7% in India, 6% in Uganda, and so on and so forth. So that globally, if you count that how many people, infected people are getting ART, out of that 7% are in India. Definitely our infection percentage of the number of people who are infected is probably around 6% or 7% only. So it is, you see that proportionate. Now people living with HIV by country, okay, 6% in India. Globally, if you see that, how many people are there, 6% in India. And if you see that ART access 7% in India, that does not mean that all people who are infected in India are having ART. If say 1,000 people are having infection, out of that if 50 people are having ART, out of 50, 6-7% is in India. Yeah, but if you see the total infected people, only 6% people are in India. Infected people globally are India. 8% of those infected people, I mean globally, if I see that how many people are dying, in 2013, 8% of the global deaths due to HIV happened in India. We'll again skip all these things. Now, let us see the state-wise status. We have the highest number of infected, or I would say that people living with HIV in Manipur, then followed by Andhra Pradesh, followed by Nagaland, Karnataka, Goa, Maharashtra, Odisha, Tamil Nadu, Chandigarh. And India's national rate is 0.27. In the countries where we have the prevalence rate more than 1, we call them a highly prevalent country. But India is not a high prevalent country. Only if you see that in Manipur, the prevalence rate is actually much more than 1.22. So that particular state, in that particular state, we have a high prevalence of HIV infections. Now, if you try to understand it more, how it happens in India. Injecting drug users, 7.2% among the high risk groups are injecting drug user, MSM, that is men have sex with men, FSW, that is the female sex workers, and who are having STD, sexually transmitted diseases. So out of all these 4 categories, 4 groups of people, IDU, that is injecting drug users, men having sex with men, female sex workers, and STD. These are the high risk groups. In that, 7.2% IDUs are actually infected. MSM 7.4%, FSW, female sex workers 5.1%, and STD 3.6%. Now you can understand, if you go back to this particular diagram, in Northeast the main problem is actually IDU. Yeah, through shared needles. And in Andhra Pradesh and in Tamil Nadu, in Maharashtra and Karnataka, in these places, because of a lot of trafficking, because of lot of unprotected sex, because of lot of sex trade, this is getting contaminated. And it might be through the brothel, it might be through many other routes. So there is a typical pattern in India. If you see that, first of all, if you see that Northeast, the typical pattern is mostly through IDUs, and it is not that only IDUs, it is also through MSMs and FSW and STD. But I would say that IDU is mainly concentrated. IDU incidences are mainly concentrated in Northeast, and in Maharashtra and Karnataka and Tamil Nadu and Andhra Pradesh, in these states, actually it is not so much of IDs, it is more of a FSW, STD and MSMs. Now the National Program for AIDS Control, we call it NSCP, National AIDS Control Program, AIDS Control Program. We started it from 1990 to from 1990. Now we are having the 4th NSCP, that is 2012 to 2017, that is the cycle. If you see that main components of this NSCP is that objective is reduce new infection by 50%. Baseline was taken of 2007 baseline. Objective 2 was comprehensive care, support and treatment to all persons living with HIV/AIDS. Comprehensive care, support and treatment. So if you see that it is not only treatment, it is comprehensive care, support and treatment. So that if you get little, I'm sorry that we don't have much time, so we cannot get into all these details. But care and support, it is whenever we are talk about HIV/AIDS program, then we talk about two things. One is that, first of all, prevention and treatment. And in treatment, we not only talk about health, medical treatment, but also we talk about care, support, and treatment. So that is very, very important. And if you see that, what are the main components of, or the key strategies of NSP 4, is that intensify, consolidate preventive services, increase access, promote comprehensive care, support, and treatment, expanding IEC services. IEC is information, education, and communication, capacity building, strengthening strategic information management system. So these are the key strategies of NSP 4. So again, I have given a lot of information at this point of time. We'll skip those information. Now, another thing what you need to understand is targeted. I mean, I'm not getting into this particular slide, but as a concept, you need to understand targeted intervention and mainstream intervention. Now, targeted intervention is actually the key risk groups covered under targeted intervention. The high risk group, as I said, that those 4 categories, and the breach population, again, these are very derogatory terms. The breach populations, a trucker, we call them breach population because there's a risk of actually they can contaminate. So that these are actually derogatory terms. So anyway, so there could be two things. One is that through targeted intervention, we try to understand what is the high risk population and through whom actually it might get contaminated and it might get spread, and we target that population. It is a very, very focused program approach. The another program approach is definitely the preventive approach, and also nowadays we have realized, and globally, at least I believe in, that once if you keep HIV/AIDS program as an isolated standalone program, the success rate globally is not that high. If you can mainstream this program with many other things, like if you have an education program, can you mainstream HIV/AIDS program with that? In your CSR program, if you are having, say, education for children, so an education program, can you also integrate some of the elements of HIV/AIDS, the prevention part, some information part in that, and gradually try to see that through that information, probably you can actually break that stigma and discrimination, so that more and more people voluntarily coming out to having, check that whether they are having any infection or not. Yeah, if somebody is getting positive status, then voluntarily that person is disclosing or not. But if mostly in targeted interventions, what I have learned is that we face a lot of stigma. We face a lot of stigma because in many cases I have seen truckers program. There is an HIV/AIDS program for the truckers. In their touch points, there are some clinics and all. Most of the truckers, they will actually not get into that because because of that the fear of getting stigmatized and discriminated. So that is why they will probably avoid to get into that treatment. They will avoid you. But if we have a more generic, like one of the corporate I was giving advice to, we had developed a truckers program, not an HIV/AIDS program, a well-being program for them. If you see that number of truckers dying in road accident is much higher than HIV/AIDS. So that for them the concern is more road accidents, more their occupational health hazards, more their road risk, and so on and so forth, than HIV/AIDS. So that if you actually start giving a treatment or start offering a program on their road safety, probably eyesight, probably blood testing, probably see their cardiac status. If you see that how to address their postural problems, small things that whether they can also carry some safe drinking water in their vehicle, is there any provision for safe drinking water or not, whether they have an identity card or not. With that, you might, as one of the components, as I am saying, that for the priority is, if you see that more people are dying in many other things than HIV/AIDS for them. So that with that, if we integrate the component of HIV/AIDS, the acceptability would be much higher and the success rate would be much higher. So probably, so that is why I wanted to say that one is the preventive and curative part. Second thing is that in curative part, you need to understand it is not medical, it is also medical care and support. That is very, very important. Stigma and discrimination, that is something we know we need to fight with. And second thing is that the third thing is that we'll have to see that whether we'll have a targeted approach and or whether we should have a mainstreamed approach. So these are the different programmatic approach we should actually think about. Now, when we are talking about ART, antiretroviral therapy, till now, this is 2012 data. Now it has increased little more. We had around 400 centers to give antiretroviral therapy, and around 1.8 million, around 1.9 million people have access to antiretroviral. Now you need to understand that it is not that whoever is attending the clinics, that means that they are under antiretroviral therapy. So antiretroviral therapy actually, I will not get into detail again, but it depends on the CD4 count. It goes to that certain level, then only it starts, but it has to be started at an early age. If it is too late to start the ART, then it's very difficult, because once that patient gets into AIDS, the syndrome status, then it's very, very difficult to treat that patient. So this is the kind of access right now we have, and as I said that 7% of the global access to ART is in India. For children also, we see that from 2005 to 2012 we have actually have done quite a bit of improvement comparing with the base year in 05, and if you compare it with 2012, so in both of these, adult and children, we have done quite a bit of significant improvement. So that in HIV/AIDS, the takeaways. One is that first of all, we need to be very, very careful about the language we use in HIV/AIDS, or any, in that matter, any disease which has a social or financial or psychological implication. Because sometimes what we do is that unknowingly we actually create taboos, stigmas, and we discriminate people without any good reason. Like that in a family till now, if somebody is having tuberculosis, I don't think that that person only suffers from. I'm giving a very simple interest. It's a very common simple incidence. It's a very common thing nowadays, tuberculosis. That person does not only suffer from that health problem or suffering, but also at the same time that person would be a little bit of discriminated. People actually get the fear of getting contaminated and all these things. So whenever in HIV/AIDS, I would say that when we use the terms HIV and AIDS, first of all, we'll have to be a little careful. HIV is a virus, and AIDS is the syndrome, when they start demonstrating showing the syndromes of HIV infection. Second thing is that when we'll, how do you call them who have got that infection? We might actually generically call them people living with HIV and AIDS, so that's more inclusive. Whereas having HIV, not developed AIDS, they are also included in that. So generally we use people living with HIV and people living HIV and AIDS. We see that there are a lot of human rights aspects and social aspects in that. It's not that HIV infection means death. There are treatments. Definitely it cannot be cured probably till now, but it can be, the immunity system can be improved a lot, and the opportunistic infections need a lot of treatment to actually to reduce the incidences, and at the same time opportunistic infections can be reduced, incidences can be reduced by proper ART, antiretroviral therapy, we saw that the most powerful medium to transmit HIV is blood, but at the same time, the most number of people, they get infected through sexual transmission. And as we can understand that, only safe sex could be the only way where actually we can prevent 85% of the transmission, because 85% of the incidents are happening through sexual transmission. So that safe sex behavior is something what we need to work on. And one thing you need to understand that, again, in safe sex campaign, there are two different schools. One school is that abstinence. They said that, it's a little bit of moral, should not have illegitimate relationship, this, that. So it's a little bit of moralistic ground, that's abstinence. Another, school is risk minimization school. They are saying is that, okay, whatever you want to do, you do, but do it safely. So it's a safe sex, so that you use condom and take all precautions. So these are the two different approaches. I mean, again, there's a debate whether we should go for abstinence or safe sex behavior, whether we are promoting morality, immorality, this, that. A lot of interesting argument can be there. But for now, we need to understand there are two different approaches. When we were talking about programs, we said that, there is a preventive aspect and curative aspect, or management aspect rather, not curative aspect. In management aspect, we'll have to look at not only medical treatment, but care and support. These are the very, very important parts. And in preventive aspect, as I said, that, there could be, again, education, proper education, through what the AIDS is getting transmitted, and also ultimately to influence the behavior, that so that we can avoid any transmission. Now, as a general, as I said, that HIV/AIDS prevention has two broad different aspects. One is the very targeted aspect, so that we try to identify people who are so-called high-risk groups. As I said, the MSMs, the IDUs, the female sex workers, they are all the high-risk groups. So that we try to work entirely focus on that and try to see that, to minimize the contamination through them, and also to concentrate on the bridge population. We call them bridge population. As I said, sometimes these terminologies are really, really not very dignifying terminologies. But what I feel, personally believe, and like me, many people believe that probably we might have a, more effective approach through a mainstream approach, so that don't isolate HIV/AIDS and don't try to stigmatize it more. But at the same time, if you really want to prevent that and identify that at an early stage, then what you will have to do is you will have to mainstream it with a broad-based program. It might be education program, it might be self-help group. We can train the women in the self-help group. They can actually spread the message. They can also sensitize people. They can motivate people for voluntary testing and disclosure, and go for treatment, ARV treatment. They can actually minimize the stigma, social stigma, and the discrimination within a community and the society, so that it can be mainstreamed, and it could be a more effective way of doing the program. For ART access, as I said, that in India we have improved a lot, but still a long way to go. With that, we'll start tuberculosis. Now, again, what is TB? Is an infection disease caused by a bacteria called Mycobacterium tuberculosis. It is, everybody knows, most common site is in the lung. So we call it pulmonary TB. Spreads through air, cough, sneezing, person suffering from disease and excreting the bacteria, also called sputum positive case. One untreated smear positive case can infect 10 to 15 others per year. So untreated cases, can actually spread it in a large scale. Once infected, stay infected. 40% of India is infected. So that, many of us, you and me, probably are also infected. But that does not mean that we have developed the disease. Yeah. In most of the cases, I remember when I was very young and I was working in an organization, so all of a sudden, I don't know for what, we thought that we should have some kind of screening whether we have TB infection or not. And to our surprise, I think 99% of us were infected. So that we are all exposed to this infection. The bacteria is there in our body, but our immunity system is working with that, fighting with that. So we are not really developing the manifestation of that. Yeah. But if you actually see that, whether we have in our blood, we have that particular bacteria or not, you will see that most of us are probably, having the bacteria. 90% of HIV positive individuals infected with TB do not develop disease. As I said that, one of the most common opportunistic infection is tuberculosis. So if you see that 90% of them, the HIV AIDS who are having TB, they don't develop the TB. So, there are two kinds of tuberculosis. As I said, the most common is pulmonary TB, another is extrapulmonary TB. It could be in many places. Now, as I said, that TB infection and TB disease are two different things. TB infection is organism is present but dormant, cannot infect others. In your body, it is dormant, you are not infecting others, and it is also not creating that manifestation in your body. TB disease is person is sick and can transmit disease to others if in lungs. 10% of individuals with TB infection will develop TB disease. So that if there are 100 people who are infected, that means the TB bacteria or organism is there in their blood. Out of them, only 10 people will develop the disease. Each individual will active but untreated TB can infect 10 to 15 years, we say, 15 people per year. Disease may occur in first 2 years after infection. So that once we get infected, it is in our blood. In the first 2 years, the disease may occur. Diagnosis, we know the main tool for diagnosis is sputum. We'll have to, check the sputum. X-ray is a supportive tool to confirm that. Method of diagnosis of EP-TB depend on the system that is affected. EP is the extrapulmonary TB. So that, if it is in pulmonary TB, it is definitely sputum and X-ray. X-ray is a supportive system, but if it is extrapulmonary, we'll have to see where is that TB infection, and accordingly it has to be, confirmed. Now the global burden, if you see that how many people are infected by TB. 2 billion infected, that is 1 in 3 of global population. So in the whole world, out of 3 persons, 1 person is infected. 8.9 million new cases in 2004. 3.9 million new smear positive TB cases in pulmonary TB cases in 2004. Global incidence of TB is increasing by 0.6% per annum, and that's quite a high actually, increase rate. However, in Southeast Asia region, the incidence is declining. That's a good news. So let us see, if you look at this map, this is actually per 100,000 population incidences of infection. Now, the red one, mostly it is red, if you can see, that is 100 to 299% per 100,000 people. And, most of the places in the world, if you see, including India, it is under that 100 to 299 range. And 300 and more range, if you see, that those are the brown areas. In African and other countries, there are few places where we see that those brown areas. But India definitely is in that red zone. That is 100 to 299 people in 100 to 299 incidences in 100,000 people. Problem is that because of the number and other things, size of population, we contribute 20% of the global burden of TB incidences. Yeah, India alone. China, though they have more people, population is higher than us, they contribute 50%. Indonesia 6%, Nigeria 4%, so on and so forth. So that we can see that it's a major problem in India. It's quite a bit of a health problem in India because we alone contribute to 20% of the global burden. Now, in this slide, just look at those red points. 370,000 deaths due to TB each year in India. We have 370,000 deaths every year. 20,000 people get infected with TB every year. New infection. 20,000 new infection every year. 5,000 develop TB every year. Over 1,000 deaths a day. 2 deaths every 3 minutes. So today, while we will be having this session in 2 hours, that means 120 minutes, you can see that 40 people have already died. By the time we will end this session, 40 people would have died only because of tuberculosis in India. So that is the kind of grave situation in India in terms of tuberculosis. One major problem is that problem of people who are having HIV, they also get TB as an opportunistic infection. So that we'll actually discuss a little later. Now, why we are talking about TB so much? Why we have actually choose to discuss on TB, not any other disease today, with HIV/AIDS definitely, because HIV/AIDS not because of the scale. I said that HIV/AIDS because of the intensity and severity of the problem. Yeah, TB is most scale and also severe, right? So many deaths are happening. As I said, that in 2 hours when we'll be, having this session today, by that time at least 40 people would have died only because of TB. Now we see that TB is the leading cause of death in adults in India. Number wise, 4,21,000 in TB. Comparing to other diseases, it's much more than any other diseases. Worldwide, if you see that, more women die because of TB infection than any other infection. So, scale-wise, the implication of TB epidemics is much higher than any other diseases. If you see that financially, indirect cost to the society in India, indirect cost to the society is $3 billion. Direct cost to the society, $3 billion. Productive hours day lost, work days lost due to TB illness, $100 million. Productive work days lost due to TB deaths, $1.3 million. School dropouts due to parental TB is 300,000. Women rejected by families due to TB, 100,000. So that there is not only health implication and social implication and psychological implication, there is a very, very definite financial implication of TB infection. Now, if you see that since 1950, TB control program we have in India, we have different kind of efforts of TB control program. So there is an evolution of RNTCP, that is revised National TB Control Program, and now the program what we are having nationwide for TB control is called RNTCP, that is Revised National TB Control Program. The objective of RNTCP is to achieve and maintain a cure rate of at least 85% among newly detected infections, new sputum smear positive cases. The achieve and maintain detected of at least 70% of such cases in the population. Now, the unique feature of this recent, the ongoing program is District TB Control Society. Every district has a autonomous society, which is a TB Control Society, modular training, patient-wise boxes, sub-district level supervisory stuff, so that it is actually outreach stuff. I mean, outreach effort is quite strong, robust reporting and recording system. So those are the government initiatives we have. And if you see that impact till now, as I said, that in entire Southeast Asia, actually the incidence of TB is reducing. That's a good news. Cure rate more than doubled compared with earlier NTP, National TB Program. 85% global target consistently achieved 2003 onwards. So since 2003, the rate of cure rate has become 85%. So that's wonderful, statistics in fact. And we'll actually discuss about the therapy what we are using, and why it is so much improved than before now. Case detection rate is close to global target of 70%. Case fatality reduced from 29% to 4% in NSP cases, and deaths due to TB from 500,000 to 370,000 a year. So it's quite a bit of achievement we have, and over 6.3 million patients initiated on DOTS, that is directly observed treatment, and over 1.1 million additional lives saved. So the magic is done by mostly the DOTS. Why? DOTS can prolong life and improve its quality. Lifespan increased by an average of 2 years, reduce mortality. DOTS is equally effective in HIV infected person as in general population. Confidentiality is maintained. So DOTS means nothing but what we are doing is that we are trying to give the entire course as it is scheduled to that person, and the health worker is directly observing, directly ensuring that the person in front of him or her is taking that medicine. Now the main problem of TB in India, TB treatment in India is actually most of the people actually on the halfway they leave the medicine, they stop taking the medicine, and what happens is that the medicine gets resistant, and that person next time when they are getting that medicine, the medicine is not working, and at the same time what happens is that the person is also spreading tuberculosis, and in many cases it's a resistant tuberculosis. So that's a big problem. But in DOT, it sounds very easy, it sounds very simple, but it's very difficult in our kind of social context because of, as I said, stigma, discrimination, and, in many times there are actually perceived discomforts of, having these medicines and all. So people, it is a challenge to really complete the entire course of the medicine. So that DOTS actually has created a lot of good result in our country. The DOT again is that directly observed treatment. Now one more thing what we need to understand is that burden of TB and HIV co-infection. So that is why we wanted to discuss this together, TB and HIV. In 2005, as I said, that TB is one of the most common opportunistic infection in India for the HIV persons globally. Sorry, in 2005, 40.3 million people living with HIV/AIDS in the world. Globally, 1/3 of the PLHA, people living with HIV and AIDS, that is the term I was mentioning, co-infected with TB. So that 30% of the PLHAs are also infected with TB. 12% of total annual TB deaths are attributable to HIV. In India, more than 50%, just look at this, that is what is really alarming. In India, more than 50% of AIDS cases reported so far had developed TB. So that 50% of the AIDS cases have developed TB. 5% of the adult TB cases are HIV positive. In India, more than 10 lakhs people are suffering from TB-HIV co-infection. as I said that in India we have 2.1 million, that means 20 lakhs, 21 lakhs of in HIV infected people. Out of them, 10 lakhs people are suffering from HIV infection. That means almost half of them are suffering from TB and HIV co-infection. Now, the effects of AIDS on TB is the risk of developing TB is higher. As I said that, the immunity system is reduced, so that any infection, the chance of getting an infection much higher. In case of TB, it is a very aggressive infection, and when the immunity system is down, one might get that TB infection very quickly. Rate of progression from infection to is 10 to 30 times higher. TB is the most common opportunity infection. What we have said, increase the rate of progression from HIV infection to AIDS. So that once HIV infection is low, one person has got that HIV infection and that person is getting TB, co-infected with TB, that person very quickly gets into the AIDS status. So that, they started showing the syndromes, because TB is also an opportunistic infection, and by itself, it will also reduce and the immunity power with co-infection with HIV, and also that person will start getting other kind of infection. Shorten the lifespan of patients with HIV infection, common cause of death in AIDS patient. That is the most common cause, in fact. So as I said, that AIDS is not a disease. AIDS, what it happens is that the system gets weakened. The immunity system gets destroyed. So that, they get different kind of infection and diseases. One is TB, and in most common cases, in most of the cases, TB is the cause for death of AIDS patient. Now, as I said, that immune response to TB bacilli, it's less for an HIV infected person. Increase in HIV replication. Once that person getting TB, the HIV replication gets increased, because TB is also reducing that person's immunity. 6 to 7-fold increase in viral load. 6 to 7-fold increase in viral load, HIV viral load. Rapid decline in CD4 count. As I said, CD4 is that immunoglobulin or that glycoprotein that actually gives a signal, and the count gets reduced. So that means the immunity power gets reduced in that patient. Increased risk of developing other opportunistic infection. So it actually multiplies the infection once it is co-infected with TB. Now, as we have little bit of time, what we'll do is that first of all, we'll quickly try to do a recap of last session, what we could not do, and then we'll see that if we have time, I'll take questions from you. Now, before doing the recap, probably very quickly I will see that if there's any question. So I'll try to. Okay, some people are complaining about the audio quality. I hope that is already addressed. So, okay, let's do the recap quickly, and then probably we'll see that what are any more questions you have. Every 5th young child in the world lives in India. So, the 20% of the global child population is in India. That we discussed that every 2nd young child in India is malnourished. So that out of 2 children in India, 1 is malnourished. 3 out of 4 young children is anemic. 75% of children are anemic. Every 2nd newborn in India is at risk of reduced learning capacity due to iodine deficiency. Malnutrition limits development potential and active learning capacity of the child. Now, we discussed this, that India is one of the, in terms of malnutrition, one of the worst statistics, one of the worst, situation we have. prevalence of wasting in child, if you see that we are just better than two countries, Burkina Faso, and the second country, in fact, before uh, getting these statistics, I didn't know the name of this particular country, and I'm sure that many of you will not know the name of the country. Yeah, the second country, when I don't know how to take the name. And we see that Sudan, Lao People's Democratic Republic, Chad, Sri Lanka, Togo, Bangladesh, Congo, they are doing actually much better than India. Right? So this is the kind of situation. And in terms of malnutrition, if you go state-wise, then Madhya Pradesh, in Madhya Pradesh, around 60% of children are actually malnourished, followed by Jharkhand, Bihar, Meghalaya, Chhattisgarh, Gujarat, and so on and so forth. So that if we see that, as I said, discussed last time, that malnutrition is not only food, if you in terms of, we talk about 3 A's, right? One is that availability of food, that is totally financial, that whether we can afford to get the food or not, food is available or not. Second thing is accessibility. Accessibility is not at all, in some cases it might be financial, but there are many other complex issues in accessibility. It might be gender, it might be social caste, it might be social groups, it might be many other issues. So whether it is accessible or not, nutrition is accessible or not, as I said, that there are inter and intra-family food security problem, so that within the family we see that there are discrimination in terms of nutritional access. So that we need to understand it is much more complex than the financial capacity. And the third part is that whether we can absorb nutrition. So that these 3 A's we need to remember: availability, access, and absorption. If we can ensure all these 3, then only we can ensure. So that we see that in our states, in these 3, what is the problem. Now, as we said, that malnutrition or child malnutrition in this case, as we are discussing, is actually a manifestation. But there are many underlying causes for that and different level for malnutrition. So if you want to understand malnutrition, then we'll have to explore those different causes at different levels. We'll have to definitely, if you start from the bottom, the potential resource, economic structure, political and ideological structure, as we said, that what kind of policy we have, what kind of government strategies we have, what kind of financial structure we have, capacity, buying capacity of people, availability of food and all. These are actually at the bottom. These are the fundamentals of our nutrition. And at the next level, we see that the resources control, human, economic, and organizational, what kind of programmatic structure we have, what kind of distribution of financial resources we have, what kind of sensitization and education people will have. So those are the human, economic, and organizational aspect. Even if we have food, if we are not really educated, we don't have that awareness what kind of food has to be done, or even if we have a policy but right kind of organizational and economic structure is not there, probably that program cannot be executed at the next level. And the third level, if you see that what are the causal factors: insufficient household food security. As we said, that there are 2 kind of household food security: intra and inter. Inadequate maternal and child care, right? Insufficient health services and unhealthy environment. In that case, we said that sometimes nutritional problem is intergenerational. It is not in one generation, because if a mother from childhood is suffering for malnutrition, gives birth to a child who is malnourished, and then it carries on like that. So that it might be, we'll have to have a very long-term approach to address the issues of malnutrition. Insufficient health services and unhealthy environment, so that the disease load would be much, infections would be much more, so that whether the person is getting enough, even if the person is getting enough nutrition, it would be wasted through infection, and entire nutrition cannot be use for the body. Then we'll have to look at the dietary intake, we'll have to look at the disease burden, and then we see that the entire thing in a cumulative manner, in a spiraling manner, it is actually manifesting to child nutrition, child malnutrition. So that if we want to understand malnutrition, then we'll have to really understand it from different causal perspective, and then only we can develop a right kind of program. So if for example, we said that if you have malnutrition program and we are supplying food, but at the same time we see that for children, and for the same time we see that there is a recurring, infection existing in that particular group of children. It might be, diarrhea, it might be any other infection, or worms are there, in the children's stomach. Then definitely we will see that our only food supply to the children will not work. At the same time, we'll have to understand what are the local government services, what are the NGO services, what are the education level of the parents, what is their financial condition and all, so that definitely we should have a more comprehensive approach toward nutrition or addressing the problem of malnutrition. Now we discussed that it is a life cycle approach. Whenever we take mother and child health or nutrition as a program, it is a life cycle approach, so that we'll have to see that, and otherwise we cannot see that particular impact what we are intending to have. From adolescents to women who are at reproductive age, to neonatal, the children, the babies, the infant and the child. So at all age groups there are specific nutritional and health requirement, and if we are not doing that, it is accumulating. Sometimes it is not that at particular age we have not met the nutritional and health need. That means the next period would be fine. That particular previous period was bad. It is not like that. Most of these impacts are accumulative, so that if there is a gap at some point of the life cycle, the gap would be accumulated, might be accumulated, and that's why we need to have more life cycle approach, so that we can address the problem more effectively. We mentioned about different nutritional programs, integrated child development services. We have NRHM, we have vitamin A deficiency program, this National Prophylaxis Program for Control of Vitamin A Deficiency, midday meal program, National Control of Iodine Deficiency and Disorders, etc. And we also discussed that if we really want to do program, and it's better to have a more complementary approach, because these are the massive programs we have in India. Try to see that in your particular area or at a national level, at whatever the level you want to work, what are the strategic areas where specifically the corporates can bring value to strengthen that existing program. Now we spoke about anemia. There are three major problems associated with anemia: reduced physical development, decreased work output, decreased work capacity, impaired sexual and reproductive development due to anemia, then reduced cognitive development due to anemia. So these are the three major areas due to anemia we see the manifestations of anemia. And we said that generally if you see the hemoglobin count is below 8, then it is alarming. Then for anybody at any age group, male, female, then we should actually seek very right kind of support and treatment. Anemia wise, again I see that as I said, that nutritional status in India is really in bad shape. If you look at anemia, the proportion of population with anemia, below 11, the hemoglobin count rate is below 11. That is the cutoff mark we have taken. Now India is 74.3. Bhutan is little worse than India. Nepal is little worse than India. But all other neighboring countries are much better than India. Right? So in that terms, in this particular term, Sri Lanka is doing much better than India. Pakistan is doing much better than India. And Bangladesh is doing much better than India. Yeah. So we are just ahead of Bhutan and Nepal. Now, if you see the MCH, mother and child health, the maternal mortality rate, what India is contributing to the world, mortality rate is 19%, right? So just we are behind the entire sub-Saharan Africa. 19% we are contributing, so that's quite a big problem for us. If you see the second box, in terms of numbers, it is the largest number of child deaths, approximately 15.8 lakhs under the age of 5 years in any country. The reasons for this are a large birth cohort and child population and a relatively high child mortality rate. So we have quite a large problem. I mean, severity, intensity, scale-wise, we have large, really big problem in hand. And if you see that causes of under 5 child deaths in India, most of the deaths are actually preventable. Most of the deaths are more on the basic healthcare, caused by basic healthcare, delivery system, and nutritional, aspects. Now, we also mentioned that RMNCH plus A, that is the anchoring program in health services. So that is supposed to actually converge all the health aspects. It might be, nutrition, it might be mother and child health, it might be immunization, all these health components as a package to the targeted population. That is what we discussed about nutrition and mother and child health. Let's see if we have missed anything. No. Now let's see if there's any question. Well, Mr. Bhuvaneshwar Mohanty is asking that how can we make AIDS and TB control as a part of CSR activity? I mean, it's little difficult for me to answer that in short. But as I said that, if you are a corporate, realistically what happens is that these are a very stigmatized areas to work on. You need to first of all understand that, recognize that. Otherwise, actually, we might create bigger problem for people and bigger problem for the company also. What I would prefer, I mean, there is nothing right and wrong in the approach, but what I prefer is a more mainstream approach toward health, a broad health, and so the TB, and HIV/AIDS programs that might be integrated in other programs like education. If you have an SHG programs, if you have a health program, so that what will happen is that we will not actually create a stigma within the program. So if you call it an HIV/AIDS program, one of the big corporates I was working with, they wanted to have a very robust health program for their employees. Now, the first of all, they in their health policy, they don't want to talk about HIV/AIDS because they were unsure. And even we saw that, most of the people, they don't want to really go to the corporate facilities for the health problems because they have a fear that the company itself might discriminate them. If there's any infection, if there's any problem, cardiac problem, even lifestyle problem, even there might be discrimination, and their performance, I mean, their remunerations and rewards might get affected. So that is why people even don't want to disclose that. So that what I would say that even for the community, if you want to have a TB and HIV/AIDS program, first of all, it should be on the basis of complementarity. Try to find out what are the government programs that are there and try to see what are the gaps you can fill up. How do you strengthen the government program? Number one. Number two, that if you really want to actively implement HIV/AIDS and TB program, then I would prefer a more mainstreamed approach than a targeted approach or a standalone approach, so that you might actually have a better acceptability of this program. Can we get few examples of programs run by corporate on health issues? There are numerous number of examples. I mean, I don't know what are the examples I give. And I'm not sure whether I should mention the names of the corporate or not. But I see that there are major programs. See, there are again two types of program. One is that at community level, people are implementing health programs. But I see at least couple of good big corporates. What they are doing is that they are working at a very macro level on health issues. One is definitely, I'm taking the name. I hope they will not mind. ICICI Bank, ICICI group of companies, they are doing a massive health program in 2-3 states, and I know that for a long time they have been doing quite a good program. There are many other organizations who are working on health, like another experimentation I know. One corporate is trying to actually create good access to diagnostic opportunities, diagnostic facilities at a low cost for people. So that is also another good approach. I saw that this is a very business model they have brought in. This is not a typical service delivery and typical welfare kind of program. But what they are trying to do is that they are trying to see that how they can offer state-of-the-art diagnostic facilities to people at a very low cost, but it is a business-based model. That is something that is very interesting, and see that how we can actually have better outreach with diagnostic tools. There are many other health programs. I mean, I don't know. I mean, what are the things I should mention and what I should not mention. So I don't see any other question. If you don't have any other question, then we would close the session for now, for today. Okay, it seems there is no other questions. So thank you so much. Thanks. And if you have any other question, definitely you may write it to me. On the next session, I will try to cover those, address those questions. Thank you so much.